A very warm welcome, ladies and gentlemen, and dear colleagues. I am Dr. Marco Lucchetti, and I am European Clinical Manager at GL Care. Today, I have the honor and pleasure to host this third Meet the Experts session, sponsored by GL Care at Euroanaesthesia 2020. A crucial part of perioperative care is the prevention of anesthesia and surgery-related complications that may compromise patient outcomes, leading to prolonged recovery times and higher costs. Monitoring relevant clinical parameters before, during, and after surgery may help clinicians to improve postoperative patient outcome, reducing thus the incidence of complication. I would like to remind that this session will be recorded. We will have time in the end for discussion, so please, if you want to ask questions, preferably raise your hands by using the button that you see in the chat in the bottom left corner. And you will be unmuted and allowed to speak up and ask your questions. Alternatively, you can write your question down by using the chat window. Now, without further ado, I'd like to introduce our outstanding expert today, Daniel Sessler. He is professor and chair of the Department of Outcomes Research, Anesthesiology Institute at Cleveland Clinic, Ohio, USA. He founded and directs the Outcomes Research Consortium, which is the world's largest clinical anesthesia research group, and publishes a full paper every 3 days. Dr. Sessler has published more than 800 full research papers, which have been cited 40,000 times, making him the world's most published and cited anesthesiologist. More than 100 of his papers were accompanied by editorials, and more than a dozen were cover articles for major anesthesia journals. So what could I say more? So please welcome Professor Sessler. He will speak about, can patient recovery in words be more dangerous than surgeries? Professor Sessler, the floor is yours.
Great. Thank you so much, Marco. Today's topic is perioperative mortality with a focus on surgical wards. Okay. Perioperative mortality is, sorry, back here. Okay, perioperative mortality can be divided into two sections, intraoperative mortality and postoperative mortality. Intraoperative mortality is a problem we've largely solved. There's been a 10-fold reduction in intraoperative mortality in the last decade, and in the century before that, there was a 100-fold reduction. Intraoperative mortality is now so rare that it's hard to quantify. In distinct contrast, 30-day postoperative mortality remains frighteningly common. It's about 2% for inpatients over the age of 45. These deaths occur during the initial hospitalization mostly, that is under our care in our highest level healthcare facilities. To put this in perspective, intraoperative mortality is 1,000-fold less common than postoperative mortality. Or to put it another way, if postoperative mortality were a disease, it would be the third leading cause of death in the United States. There are two major causes, myocardial injury and ventilatory failure. Myocardial injury is far more common, but ventilatory failure is almost completely preventable and therefore of substantial interest. Okay, so let's start with myocardial injury. I'm sorry, these slides are misbehaving a bit. Okay, try this again. So postoperative myocardial injury is common, silent, and deadly. The incidence of myocardial infarction is about 4% among inpatients over the age of 45. The trouble is that most myocardial injury is clinically silent and is not accompanied by symptoms. Therefore, it doesn't meet the fourth universal definition of MI. Because of that, we devised a new term called myocardial injury after non-cardiac surgery, abbreviated MINS. 93% of these events occur without symptoms, and they're thought to be type 2 myocardial infarctions, that is, resulting from supply-demand mismatch. It's not just troponitis. 8.5% of patients who have a troponin elevation have a major cardiovascular event within 30 days. High sensitivity troponin, or any troponin elevation for that matter, is highly predictive for death in the 30 days after surgery. And we can see here that as troponin is elevated, the probability of 30-day mortality increases, and it increases markedly. At the highest concentrations, 30% of the patients die within 30 days. There is, unfortunately, no safe prophylaxis for myocardial infarction. Beta blockers reduce myocardial infarction, but not safely because they cause hypotension and strokes. Nitrous oxide was thought to increase the risk of myocardial injury or myocardial infarction, but it turns out that it doesn't. A corollary is that avoiding nitrous oxide won't help. And the POISE-2 trial, 10,000 patient factorial trial, showed that aspirin does not reduce myocardial injury or myocardial infarction, and it does cause life-threatening bleeding. Clonidine also does not reduce myocardial infarction, but it causes bradycardia and hypotension. Hypotension is an important risk factor for myocardial injury and myocardial infarction. Postoperative hypotension is common and it's frequently missed. So these are the results from blinded, continuous, non-invasive postoperative monitoring. And it shows, for example, that nearly a quarter of the patients had more than 30 minutes with a mean arterial pressure less than 70 millimeters of mercury. That's 30 continuous minutes of hypotension. 70 millimeters of mercury is quite low for an awake patient on a surgical ward. And yet it's common. And it gets even worse because almost a fifth of the patients had 15 continuous minutes with a mean arterial pressure less than 65. This is critically low for a patient on a surgical ward. Stunningly, more than half of these episodes were completely missed with routine vital signs. That is, every 4 hours, nurses came by to the vital signs, and they missed more than half of these episodes. Now, the reason I'm telling you about hypotension is that it matters. So this is a reanalysis of the POISE-2 data, and it shows that intraoperative hypotension increased the risk of myocardial infarction, but hypotension on the remaining day of surgery also increased the risk of myocardial infarction, and hypotension occurring anytime during the subsequent postoperative days 1 to 4 also substantially increased the risk of myocardial infarction. Similar results were just published in an analysis by Liam and colleagues. So postoperative hypotension is common, and it matters because it's strongly associated with myocardial infarction. So I'd like to go on now and talk about respiratory depression. So respiratory depression is also common on surgical wards. And as I said in this editorial, it's likely that many catastrophic respiratory events can be prevented by continuous monitoring. So let's talk about postoperative respiratory events. So let's start with saturation. So in this study, we did blinded continuous saturation monitor in patients recovering from surgery on ordinary surgical wards. And what it shows is that desaturation is common. Look at postoperative day 2, for example. More than 10% of the measurements we made on the second postoperative day had saturations less than 90%. This slide shows that by the second postoperative day, and certainly by the third postoperative day, ward hypotension is common. And just as with ward hypotension, it's frequently missed. 90% of the patients who had a continuous full hour of saturation less than 90% were not picked up by the nurses doing every 4-hour vital signs. And keep in mind that every 4 hours is relatively common. Many hospitals only measure vital signs every 6 hours or 8 hours. Showing these data a different way, this shows the duration of various episodes. For example, 10% of patients had more than one continuous hour with a saturation less than 85%. Now, a saturation of 85% by itself doesn't kill patients, but it also indicates a patient who's really fragile. No one thinks that it's a good idea to have patients on surgical wards sitting around with saturations of 85%. This is a patient who is highly fragile and can be pushed into a respiratory arrest by some little event. And as I showed you before, the nurses missed almost all of these events. Now, saturation is only one way to characterize respiratory failure. In the Prodigy analysis, we did we characterized respiratory events using various other methods. So we included respiratory rate less than 5 per minute for at least 5 minutes using continuous end-tidal carbon dioxide monitoring, saturation less than 85 for 3 minutes, end-tidal PCO2 less than 15 or more than 60 for at least 5 minutes, or apnea more than 30 seconds. So the primary outcome for the Prodigy observational cohort was a composite of respiratory events defined by these 4 different measures. Remarkably, nearly half of the patients had a respiratory event. That is really a lot. That means that surgical patients on routine wards are not mostly stable. Half of them are having serious or potentially serious respiratory events. Part of the Prodigy analysis was to see if we could predict who is going to have respiratory events. So we were able to predict respiratory events, and it turns out that advanced age, male sex, being opioid naive, and having heart failure were the primary predictors. But I caution you that this is an unvalidated analysis because there was no separate validation group for this. Furthermore, we couldn't predict very well. The receiver operating characteristics curve had an area of only 0.7, which means that you can't predict especially well who's going to have events. A corollary is that everybody really is at risk. And the reason is that it's not baseline characteristics mostly that predict who's going to have respiratory events on surgical wards. It's opioids. And you can see here, among patients who had cardiac arrests, they mostly had opioids. If they had opioids and sedatives combined, they were twice as likely to have a cardiac arrest as if they didn't. Opioids alone were also harmful. Sedatives alone were not, because sedatives don't impair respiration. But the combination of sedatives and opioids do. And this is consistent with clinical experience. If you give midazolam alone, for example, it doesn't impair breathing. If you give opioids, it impairs breathing. If you combine midazolam and opioids, it definitely impairs breathing. Okay, so consistent with this, there have been some analyses of opioid-induced respiratory depression, particularly an analysis of the closed claims database. The closed claims database includes malpractice suits that have been settled somehow. Either they settled or they went to trial. So there's no denominator for this. This is a highly selected population, but it is a group of patients who had events bad enough to result in a malpractice claim. 77% of episodes related to opioid-induced respiratory depression resulted in death or severe brain injury. 97% were deemed preventable. And this comes back to what I said in the beginning, that myocardial injury is far more common than serious respiratory events, but it's not so obvious how to prevent myocardial injury, and myocardial injury occurs in patients who have pre-existing myocardial injury, cardiovascular disease. Respiratory events are completely preventable. Nobody should die from a respiratory event in a hospital because we know how to intervene. We know how to breathe for people if necessary. So they nonetheless happen. And when they do, they're very serious. If there were nothing that we could do to prevent these events, I wouldn't be talking about it. But we can, because 60% of patients who have respiratory events have at least one abnormal vital sign 1 to 4 hours before cardiorespiratory arrest. So these patients don't just go along absolutely perfectly and suddenly try to die. Instead, they indicate that they're getting into trouble with desaturation, with apnea events. They're telling us that they're getting into trouble. The difficulty is that we don't know about it because with intermittent vital signs, we miss these warning events in most cases, and therefore can't intervene. Continuous ward monitoring almost surely helps. Now, at this point, we have not very good data to support that. Basically, we have a single before and after study, which is a very weak type of study design. But what this shows is that if you institute continuous monitoring with pager alerts to the nurses, that the number of events that required emergency rescue goes down considerably, almost by a factor of 3. and the number of ICU transfers goes down by almost a factor of 2. So I caution that these are weak data, but it suggests that continuous monitoring really helps. Personally, I am absolutely convinced that continuous monitoring is coming because it's the only way to detect both hypotension and respiratory events. So to summarize here, myocardial injury is common, silent, and deadly. 90% is missed if you don't monitor troponin. So I strongly suggest monitoring troponin in moderate to high-risk surgical patients. It's associated with both intraoperative and postoperative hypotension. And once again, if you're not monitoring, you won't know. Hypoxemia and hypoventilation on surgical wards is common, profound, and prolonged. And it's also missed by routine vital signs. Continuous ward monitoring will help. I believe that every surgical patient should be continuously monitored postoperatively. Most postoperative mortality probably is preventable. But the first stage in preventing mortality is going to be to monitor patients continuously so that we detect the events that tell us which patients are getting into trouble and give us time to intervene. What we will need is a system where surgical patients are continuously monitored, but this will generate an enormous amount of data, far more than anybody can reasonably deal with. So these data are going to have to go into some sort of artificial intelligence engine that evaluates the patterns, all the data that's coming in. So it takes ventilatory data in context with blood pressure, for example, takes information from the electronic record, relevant lab tests, puts it all together, identifies, let's say, the top 10% of patients at risk, and then sends information about those patients to someone in a bunker looking at lots of patients, preferably an anesthesiologist, who will then decide which patients are really getting into trouble and then make a call to the ward. Hey, Tom, check bed 4 now. That's how we're going to prevent these events. So with that, thank you very much, and I look forward to questions.
Thank you very much, Professor Sessler. This was really a very interesting perspective on this topic about patient deterioration in the wards. I think this is really interesting. Are there any questions from the audience? I don't see any hand raised, so maybe I will break the ice and ask you one question on my side. Is it possible to predict which patients are at risk for ward respiratory events?
The answer to that is mostly no. So the Prodigy analysis did generate a prediction algorithm, but first it's unvalidated. Okay, you cannot develop a prediction algorithm and then test it on the data you developed it from. You need to test it on an independent data set. And when you do that, you always find that it's not as good as you thought. But even with the caveat that it was developed without validation, it wasn't very good. Okay, better than nothing. I'm not saying it's worthless, but my interpretation of the Prodigy prediction is that we cannot reliably predict who is going to get into respiratory problems. And a corollary is that because you can't predict, you really should monitor everyone. And I'm absolutely convinced that continuous ward monitoring is coming. It is coming, and probably faster than you think, because only continuous monitoring is going to detect hypotension and allow us to intervene and perhaps prevent myocardial injury. Only continuous monitoring is going to detect these patients who are getting into respiratory problems, who are having these short apnea spells, who are having a respiratory rate of 4 for 5 minutes. Okay, that per se doesn't kill them, but it's a warning that this patient is likely to have a respiratory arrest. With continuous monitoring, we can identify these patients and intervene and prevent the respiratory arrests.
Thank you. Thank you very much. We have one question from Dr. Ali Saad. Do you recommend using PACU criteria for any patient for shifting to wards? So I guess criteria for discharge patients to the ward from PACU.
I don't have a strong opinion about that. I think if you monitor patients on the ward continuously, then the ward in many ways becomes an extension of the post-anesthesia care unit. And that's what's required, because clearly patients are at risk for days after surgery. It's not as if keeping them in the recovery room for another hour is going to solve this problem. Yeah. The problem is not that we're inappropriately sending patients to surgical wards. We probably do a reasonable job of making sure that they've acutely recovered from anesthesia. The events that we're seeing on surgical wards are not from residual anesthesia. They're mostly from opioids. And the need for opioids continues for days. People who stay in the hospital nowadays stay in the hospital because they're sick and because they had big operations. Everybody else goes home. These are high-risk patients. To put a broad view here, in the last half century, we've moved from a situation where people would come into the hospital at least a day before surgery, and they would stay for a week or two after surgery, mostly being perfectly healthy, just recovering, waiting for their wounds to heal, to a situation where everybody who's reasonably healthy, even people having large operations now, they're doing hip arthroplasties and sending people home. Everybody who's semi-healthy goes home. The patients who are left in the hospital are now much, much sicker than they used to be. But our routine for ward vital sign monitoring has not changed in half a century. It is not keeping up with the fact that patients in hospitals now are just so much sicker than they used to be, but we monitor just the way we did a half century ago. This has got to change.
Thank you, Dan. One more question is about troponin. The troponin can be elevated even in mild renal insufficiency. If we manage to optimize renal function, can we optimize the incidence of means, I guess, mild renal insufficiency post-op? And in general, I would say, who should have troponin screening?
Okay. Okay, bunch of issues there. Okay, so first of all, myocardial injury after non-cardiac surgery is defined as a troponin elevation that is thought to result from myocardial ischemia. It's not just any troponin elevation. Second point, mild renal insufficiency does not increase troponin. Even dialysis dependent patients, even end-stage renal failure, does not much increase troponin. There are some causes of troponin elevations not resulting from cardiac ischemia. It happens in sepsis, it happens in pulmonary emboli. They're rare. Please don't look at elevated troponin and find some excuse to not believe it. It's almost always cardiac. In terms of who should have troponin monitoring, in patients having over the age of 45, having moderate to high risk surgery should have troponin screening. And it should be 1 day, it should be preoperatively and for 2 postoperative days. 94% of myocardial injury after non-cardiac surgery occurs within 2 postoperative days.
Thank you. I guess as we are really over time, I would just ask one last question, very short answer if you can. How do you see the potential after effects of the current pandemic on potentially needing to expand the monitoring capability for patients? Could continuous ward monitoring play a role here? So in the new pandemic era?
Mm-hmm. Well, one of the consequences of the COVID pandemic is that it's now difficult to go in and see a patient and take vital signs. It requires getting fully dressed up and gowning and gloving and protective equipment. Continuous monitoring would give us information on all patients all the time, and then the nurses could focus on the patients who are sickest, which is what we want them to do.
Thank you. Thank you so much. And very short answer to Isabel, absolutely yes. If we don't have a rapid response team, we only count on the efferent part, but not the efferent part of the response. So absolutely the two should move together, because if we have only one, our system will not work how we want to. So unfortunately, we are just at the end of our time. So I would like to thank you so much on behalf of GL Care. I would like to thank you so much, Professor Sessler, for being with us today, for your time and for your excellent talk. And dear colleagues, thank you for your time, for your attention, and even more importantly, thank you for what you are doing every day to care for anesthesia patients. Stay well and bye-bye. Thank you.
Thank you all.